As I handle this presentation focusing on stakeholders, I want us to think about an orchestra. Whether you are playing the violin or the piccolo, you have a role in that orchestra. And that's the spirit in which this presentation is going to be made. But at the center of that is the patient, who is often missed by the health workers, and the newspaper has to pick that patient and bring him or her to the limelight. This is a picture of a patient who appeared in one of the Ugandan newspapers, and the journalist was highlighting the need of that patient. I'll focus on the global stakeholders and their roles, stakeholders at a national level, and then the orchestra, how it plays nationally and internationally, and then the key models from Africa. I liked the resolution when they talked about it focusing on health systems rather than specific diseases. And of course, my colleagues have already highlighted the disadvantages of focusing on specific diseases rather than the whole. We've also heard about balancing control and access, and the resolution, especially in the preamble, talks about that. It's therefore stakeholders alone cannot act unless you also balance the people that you include in your team of stakeholders, both at global and at national level. The resolution brings out the key players, especially at the global level. We know that the member states are supposed to do their job. They have 9 roles in the resolution. The training and education institutions are talked about, civil society, the Director General, and other international agencies. But of course, patients associations, organizations, and family members are mentioned. When you look at the resolution, for us to clearly get the key stakeholders, it's important to look out for the P. Person-centered appears in there. So if you are to provide person-centered care, who are the people that you need? If you need policies, who are the people you need? If you talk about primary care, who are the stakeholders? If you talk about the problems, who is able to comprehensively address those problems? When we talk about providers, do we limit ourselves only to doctors and nurses and social workers, or we go beyond? When we talk about public-private dimension, that is mentioned in the whole document of the resolution, who are the stakeholders to bring that happen? In some of the countries, you need an independent policy for that kind of partnership. Management of pain, children and their formulations, psychotropic medications, and then the procurement systems, and then the underlined word for me is partnerships. I think it's very important for us to think about the partnerships when we talk about stakeholders, and of course the plans. But one of the key issues in Africa especially is the issue of prescribers, because who prescribes the opioids that we are talking about? That's a big challenge in Africa, especially where you have, maybe in some of the countries like in Uganda, 1 doctor to every 20,000 people. And then the principles of palliative care training and education, who are the stakeholders in bringing that to happen? And who are those responsible for promoting the implementation of palliative care? For us to make progress, we need to have good practices, we need to focus on the poverty-stricken countries, and we also have to balance that with the prevention of misuse, as my colleagues have mentioned, but also ensuring that our patients get the psychosocial support that they need. The Global Atlas brings out all the conditions for which palliative care is needed, both for adults and for children. Now, when you look at these conditions, who are the stakeholders that we need to engage to deliver a comprehensive package, both at the patient level and at the system level? The Atlas, of course, gives us the gaps that we have in Africa. I pulled out the African gaps, and you can actually see majority of the countries where nothing is happening actually in Africa. And therefore, focusing on stakeholders in each of those countries is not going to be easy, but it must be done for us to improve on that so that by the time they work on the new Atlas, there is some progress. My colleagues have talked about the global level. WHO, of course, we look forward to supporting member states, the evidence-based guidelines, research models, and supporting the reporting frameworks, of course. And children, UNICEF, balancing with INCB and UNODIS to make sure that we have that balance. Member states, funding, policies, education, essential medicine supplies, partnerships with civil society. Those are all key issues that call for identification of stakeholders. And of course, us in the civil society, as well as the academic world. At the national level, the Ministry, of course, of Health focuses on the 6 building blocks. But for it to do that, it needs other ministries, Ministry of Education, Ministry of Finance, Social Welfare and Community Development. These are all stakeholders in the countries. And then you need Health Service Commission, who is going to start rewarding the people who have been trained as palliative care specialists. This is a big debate now in Africa where training is happening. National medicines authorities or medicine control councils and national medical stores. Register medications, ensure that the medications are distributed. These are all people that you need. We often forget narcotics police. In fact, there are many police people who do not know that narcotics are used for patient care. There are many. And so whose job is it to make them aware that they are also used for treating patients? National Councils of Higher Education, they accredit courses which we want to set up for palliative care. Universities and other institutions, of course, we all know the role that has been mentioned already. Professional councils for doctors, nurses, social workers, and all the others. And of course, the national palliative care associations. In Africa, we have now 21 countries with national palliative care associations. And if you look at where most progress is, apart from Swaziland, it's countries where you have national palliative care associations, with South Africa on top in our continent. Hospices and community and home-based care providers, these are key in the provision of the service. And of course, the human rights commissions are now, we think that they should also include palliative care in their monitoring as well as in the report that they give out, as well as patients and patients' organizations. Talking about country models, we've looked at a number of issues that determine those models. Financial aspects and other resources, the existing health system, the environment for public, private, or not-for-profit, private not-for-profit, and public versus with private for-profit, and the partnership that they share in bringing forward service delivery. We are almost convinced in Africa that governments can never be able to provide palliative care as we need it. It has to be a partnership with everybody else, whether they are for profit or not for profit. We've talked about understanding the medical conditions, but also the aging process and how it is affecting the palliative care in those countries, the education system, legislation on prescribers, geographical distribution of the population and the density of the population. In some of the countries like Botswana and Namibia, you have very small populations that are scattered in big countries. So your models and the role players you need might actually differ because of that. And of course, understanding the socio-cultural context within these countries. There's no model that fits everything. There are different stakeholders that need to be brought on board in each of those countries. We had an example in Botswana where the working population cannot be able to look after their people well if they are left in the house. So these are things that we need to think about. Now, in terms of models, I think we have the Ugandan model, and Dr. Anne Merman is here, who was a pioneer in the Ugandan model, where government partners with Hospice Africa Uganda to ensure that we have access to opioids. That was a breakthrough. Of course, there are people who have misunderstood that model. They think that government maybe is not taking its full responsibility. But the history of that country is that almost 40% of healthcare in that country has been always provided by civil society and churches. So that partnership is very critical. Then you have the legal and human rights approaches that have been included with the support of OSF, where patients, health workers, and the general public have access to that information. And then you have Tanzania, where they have decentralized the reconstitution of morphine in the regional hospitals. And of course, South Africa, they have unique models where the Ministry of Health works with Hospice Palliative Care Association, and their palliative care model in prisons. I think that's something that we all need to learn from wherever we come from. It's a unique model. And then the accreditation system for palliative care standards. And then you have Kenya and Malawi. My colleague Zippy will be talking about the Kenya model later in the day, but it's a nice model where you are able to provide palliative care within a government facility. And then Zambia, where you have the Livingstone General Hospital model. And then Swaziland, where everything is government-led, of course with a few people providing services from the civil society side. And then you have Botswana. They have a number of models, hospice in a hospital and the retired nurses model. Many of us don't think of retired nurses as resource people that can play a role in providing palliative care in the community, but in Botswana they are doing that. If we do that, maybe we'll be able to improve the figures, as you've all been talking about them, as regards opioid consumption in our countries. As regards legislation and policy level, Africa has 6 countries with policies now. That is Swaziland, Zimbabwe, Malawi, Tanzania, Rwanda, and Mozambique. Uganda and Botswana are working on their policies at the moment, and the drafts are ready. In Botswana, we're supported by CDC, and in Uganda by American Cancer Society. And then Uganda also has a statute where nurses are allowed to prescribe opioids. Now, you can never deliver palliative care in Africa unless you have full involvement of your nurses, and they are empowered to do that. They are key stakeholders. They are key role players in that. And then you have countries in Africa that have integrated palliative care into their national cancer control plans. You have Kenya and Zimbabwe as model countries. And again, we need to encourage that throughout the continent. And then we also have countries that have set up national palliative care task forces, where you have different players coming, getting involved in that. Now, they are at different levels of development, but we have Uganda, Kenya, Botswana, Namibia, Malawi, Zambia, and Mozambique. And then education. We've been talking about palliative care education. South Africa, Kenya, Malawi is developing theirs, and Namibia has integrated it into social work training. And that does not take away the challenges that we face. The funding. I'm sure all the Africans, when we were voting, looked at the funding side. The poor coverage that we have. Palliative care in academic and teaching institutions. Poor access to opioids. Refugees and internally displaced persons and the disabled. Lack of policies in many of the countries. Other legislative barriers and ignorance, not only of the public, but also of health workers. And of course, the human resources. As a way forward, we need governments, teaching institutions, civil society organizations to build systems that sustainably fund palliative care. We need to strengthen health work training. We need to invest in palliative care research. We need to support the reporting mechanisms so that we get the proper information that we need, and developing programs for key populations. On the APCA side, we are, as an organization, we've been able to, and we are ready to work with everybody to ensure that that happens on the continent. And of course, we shouldn't forget our partners who have in the past and are continuing to support the palliative care movement on the continent of Africa. They are our role models and they are our supporters. Just to say that we also look forward to meeting you in Africa as we host the Palliative Care Conference in August next year. Thank you very much.